Good afternoon, good evening, dear friends. Greetings from Indian Arthroplasty Association. I am Shubhranshu Mohanty. I am being the present president of this August association. Welcome you all to this webinar, which all of us are looking forward to. This pandemic has taught us many things. This pandemic has taught us how to handle our personal life as well as professional life. And now, being arthroplasty surgeons, we need to know how to handle arthroplasty in our professional life as well. And Indian Arthroplasty Association, being the most premier association of this country, devoted entirely to the practice and teaching of arthroplasty in India. And this year we are celebrating our silver jubilee year and completing 25 years. And you can go through our website, indianarthroplastyassociation.com, to know more about our association and give your suggestions at this email ID, indianarthroplasty@gmail.com. Friends, during this pandemic, we have been conducting webinars, and this is our webinar number 7, which is totally devoted to the arthroplasty practice during this pandemic. And we have rightly named it as New Normal in Arthroplasty Practice, the Way Forward. And I've been extremely thankful to Johnson & Johnson for supporting this event entirely. And I thank Mr. Balaji Ramamurthy and the entire team of Johnson & Johnson being the backbone of this webinar. Now with me, Dr. Sanjeev Jain, who is a consultant orthopedic and arthroplasty surgeon at LH Hiranandani Hospital, Mumbai, is there, and he will be moderating this session. He is the present Vice President of Indian Arthroplasty Association as well. And I welcome Dr. Sanjeev Jain to moderate this webinar. Dear friends, we have three global stalwarts there with us to share their experience. And first, let me introduce Professor Weya Zhu, who is the Deputy Director at Wuhan Union Orthopaedic Hospital at Wuhan in the Hubei province in China. And all of us know that this is the epicentre of this coronavirus, and they have their first-hand experience how to handle this virus and how to handle arthroplasty practice during the lockdown period and after the lockdown period. And we are very fortunate to have Professor Zhu with us today. Welcome, Professor Zhu, to this webinar. Next, we have Professor Seung-Hoon Baek, who is from South Korea, and he has MD, PhD, and MBA, and is Associate Professor in the Orthopaedics at Kyungbuk National University and KNU Hospital of South Korea. And as you know, that Korea has been very instrumental enough to contain this virus and very well. And we will know the first-hand experience from Professor Baek, how they handled the virus and how they practiced arthroplasty during the lockdown period and after it. And last but not the least, Dr. Michael Gillespie, who is from Canberra. He's a consultant orthopedic surgeon at Canberra and the sitting first Vice President of Australian Orthopaedic Association, and will take over as the President in October this year. And Professor Gillespie, as you know, that he has got 31 years of clinical experience and the former President of Australian Orthopaedic Registrars Association. So from the period of residency, he is active in the orthopedic politics. He is a founder member of Australian National Gallery Association, member of the Friends of the National Portrait Gallery as well. And we have been fortunate enough to have Dr. Gillespie with us. And as you know, in Australia, there was a wave of coronavirus, and probably there is a second wave which is going on now in the news. So he will give us his experience about this, how to handle arthroplasty. Now, in addition to that, we have a galaxy of our Indian faculty. First, Dr. S.K. Maria. He is the chairman of orthopedics at Max Healthcare in New Delhi. And Dr. Maria has been the past president of Indian Orthopaedic Association and Indian Arthroplasty Association and Indian Society of Hip and Knee Surgeon as well. I welcome Dr. Maria, who has a vast experience in arthroplasty and as well as in administration of hospitals. We have Dr. Bharat Modi, who is the past president of Indian Arthroplasty Association as well, and he is the chairman and CEO of WellCare Hospital at Vadodara, and he is an experienced arthroplasty surgeon both in hip and knee, and he will show us the way in India. Next, Dr. Rakesh Rajput. He is also involved in the administration and practicing arthroplasty primary and revision at CMRI Hospital, Kolkata. And Dr. Rajput is the present Joint Secretary of Indian Arthroplasty Association as well, and he will share his experience from the east side. And last but not the least, Dr. Krishna Kiran, who is from Hyderabad Medicover Hospital, and he has started arthroplasty practice during COVID times, and again he has gone back and quarantined himself because of more number of cases from his hospital, and will know about his experience also. So dear friends, it's from north, east, west and south, southern parts of India, all four parts. We have four eminent faculty there to discuss about it. Dear friends, let's have a nice webinar today, and all of you, I request that you ask questions anytime. We'll share your questions with the faculty and go ahead with the discussion. I thank you for a patient hearing, and now I hand over to Dr. Sanjeev Jain, who is the moderator of this webinar. Over to Sanjeev, please.
Can I share the screen now?
Yes, sir, we can see your screen.
All right. So thank you, President Mohanty, and again, welcome to all our international faculty and national faculty. Today's topic is really a burning topic, and all of you are aware of that. The whole practice of medicine is disturbed as far as the non-COVID practice is concerned, and especially in orthoplasty, it's really a challenge to start one, and I'm sure that not many surgeons are performing a planned or elective arthroplasty today in the country. This virus has really had a very negative impact on the world, and definitely in orthoplasty practice in India as well. There are many issues, and I'm sure we have an extreme faculty, which is like Dr. Bharat Modi, who's owned his hospital. He would definitely come back to us with some certain financial issues, which is going to come back on Indian arthroplasty scenario and then hospital management. When we are going to start elective hip and knee arthroplasty, definitely not aware of it right now, because in India the cases scenario is not good all over, and it's going up and down, and it's still the lockdown is not over. The virus is not 100% under control. So we have to have a new norm which is going to come up and affect us, and we are going to have a lot of issues which we need to deal with it. So revenue of the hospital, their cash reserves, they're quickly depleting cash. These are the major factors even into run the hospital and orthoplasty setup in India today. The most important problem in the hospital is also there to maintain their underutilized staff there, to pay their salary, and also to protect them this virus and keep them healthy to run the hospital and the incoming when the lockdown is over, the practice. I think that's going to be a challenge. I'm sure that as people may be operating on a arthroplasty scenario, only probably what we feel is in a hip arthroplasty post-fracture neck femur. Probably that is going on and nothing else is going on in most of the places. But everybody has to perform certain protocol-wise the tests and be very careful, which we are doing as well, that you need to have naturally the test for all the patient which we are performing if we are doing any kind of semi-emergency arthroplasty in a fracture neck femur especially. Naturally, you have a lot of true false negative tests, which is an asymptomatic patient could be a worrisome factor and which we need to take into consideration. And then naturally, once the test is positive, you can delay the procedure as recommended, even in the literature, and which we are doing as well. Now, the most important thing is how to use a personal protection equipment. There are different protocols at different setups, but there is a set protocol how to wean off and wean on. We need to definitely think about in a protocol wise. We need to protect our hospital staff. We have to protect the patients and everybody. But what is more important also, it has been published even from Wuhan that N95 mask or respirators is the key, which should be used by each and everybody, especially even in operation theater, all the surgeons, staffs, and everybody. You have to minimize, if you are doing a practice currently today, the number of people staying within the operation theater. The challenge is with the anesthesia, when there is an airway management is done, then definitely in this COVID-19 patient, we need to be really, really careful about it. So there is a special consideration for the surgical process and the anesthesia side, which needs to be followed up, which is, I'm sure that whomsoever is doing an arthroplasty in India, especially on a COVID patient, on a fracture neck femur, they must be following certain guidelines. And the guidelines keep on changing day by day, especially when the management of the COVID patient is concerned from the states and from the different hospitals as well. But we have standard guidelines. We need to follow that. We have an excellent hood system, which was there in orthoplasty scenario. But these hood system, we have to be careful about it, not to put positive pressure. So we can modify these hoods and really, really use, in a better way, contemporary to the general surgeons, and we can protect ourselves as well. Now, what is happening here today? A lot of young orthoplasty surgeon, who's a budding orthoplasty surgeon, because there is no cases at all which is coming up in general in most of the places where the number of cases are very high, lockdown is not over. They have suffered financially. Some people have lost their job, and that's a scenario which is really, really bad in current scenario. Even I can vouch in many places in the country as well. What is the role of orthopedic surgeon if not in the orthoplasty side and the COVID side? There are different government guidelines. There are different orthopedic bodies, or there is, like in Maharashtra, there is a Maharashtra Medical Council. They're asking even the surgeons to help the physician. And what is the role of the surgeon there is basically to counsel the patients and patients' relative, teach them the whole hospital system, educate about their hygiene, social distancing. And I think that's the key factor where the orthopedic surgeon can play the role, because we can't do much on the medicine side managing these patients. We have to help in disrupting the chain of the pathogen transfer by various ways, which has been laid down as per the guidelines. Important measures, very simple things that we need to, if we are running a hospital, orthopedic hospital, we have a COVID patient, a non-COVID patient, we need to have followed all sanitization and sterilization protocol, using the mask, how long mask has to be used, which mask has to be used, whether we can sterilize, whether we can use them safely after sterilization. All the things has to be followed as per the guidelines given in the literature. We have to follow certain protocols, which we are doing it in our hospital. I'm sure that most of the doctors and most of the orthoplasty surgeons are doing as per the protocols, and they are checking all these points when they're performing the surgery during this COVID time. But what is most important is this: the financial impact is really throughout the country and throughout the worldwide is unprecedented. And definitely there is huge number of surgeries reported. It's been cancelled, and probably in literature they're reporting that 37% of the hospitals practice have closed down. And we don't have any data in India, but we are sure that we have also the same situation that people are, if it runs for next 3 to 4 months, I'm sure that the things will be different financially to many of us. So to conclude, that this pandemic has taught us a lot of new things in an India and orthoplasty scenario, but I'm sure, and this will be there and will be felt with the year to come. There would be society, there will be a lot of changes to fit and treat this kind of scenario by an isolation. And there will be a lot of attempts to come to the near normal life. We really don't know how we will be coming back on a surgical side and even social side on a normal life. We are really hoping for an effective vaccine and their potential treatment of this virus. If which comes, then probably the scene of the orthoplasty, scene of the social life and hospital will definitely change. Of course, we need to be very careful about it, protection of ourselves, our staff, to put really a chain to stop this pathogen transfer. I think that is the real thing which we are looking for it. So with this, I will conclude that it's the same which is on Indian orthoplasty scenario as well. And I will invite the next speaker, as Professor Baik, and he will be speaking on safeguarding the patient and staff during the procedure. So Professor
Professor Jew first. Professor Jew is there first.
How did our orthopedic practice changes during lockdown, a Wuhan experience? Sorry. Yes, Professor Zhu first. Is he there?
If he needs some time to prepare, I can go first.
I think I can see Professor Zhu is there. So Professor Zhu, my request is to start with your, yes, he is there.
So while Professor Jew is preparing, loading his presentation, so we have divided the entire discussion into two parts. The first part is the practice during lockdown. Then we'll have a question answer session, then followed by the practice of arthroplasty after the lockdown, that when we unlock ourselves. And then there will be another set of questions and discussion will be that. So Professor Yu, welcome, and I can go ahead with your presentation, please.
I think he has to unmute himself. Probably he's done it. Yes. Professor Zhu, can you hear us? He's speaking, but we can't listen. Mobin? Mobin, are you there?
Yes, sir, I am there.
So what is the problem with the Professor Zhu?
It just said Professor Zhu left the call. You just got a message on the screen saying Professor Zhu left the call. So he's disconnected as of this moment.
So we'll take the Professor Baik first and then sort it out.
Okay, I will go first. I'm Sung Baek from South Korea. We Koreans experienced outbreaks twice. The first outbreak happened in my city, Daegu, on February, started from missionary. 85% of patients were in and around my city. My talk is safeguarding during the procedure, but we need to define which procedure can be performed depending on the stage of this pandemic crisis. So my talk will include triage and safeguarding during the procedures. American College of Surgeons recommended all elective surgeries to be minimized and the urgent surgeries to be shifted to outpatient setting during pandemic crisis, but COVID-19 conditions are highly variable across the country or depending on hospital level, and those conditions are very fluid. Though each country has a unique system for alert level, they have color-coded system in common: green, yellow, orange, and red. It came from alert level for volcano eruption, and Singapore government developed color-coded framework that shows the current disease status during on the severity and spread of the disease. Other
Professor Beck,
countries
are you
also have.
sharing your screen? Are you sharing your screen?
Sorry?
We can't see anything. Are you sharing your
Can see
screen?
your screen.
Oh, I will check. Yeah.
Professor
So can
Zhu
you
will
see?
take you after this talk. Yes, now it's coming up.
Oh. So go ahead or start from the very first one. So now, well, I will continue. Other countries has also have similar system. ACS, American College of Surgeons, has organized the triage and management guidance into 3 acute phases. Local hospital resources and trajectory of pandemic determine the urgency of acute phases. What surgeries can be performed depending on the stage of acute phases? Surgeries for treating dislocation, infection, and fracture can be performed during phase 3. Surgery due to acute pain may be performed during phase 2. Now you decided to go to OR, you need to have personal protective equipment, PPE. Personal protective equipment includes face mask or respirator, protective eyewear, head covering, gowns and gloves, and shoe covers. To avoid self-contamination is first step. If you see the panel B, COVID virus can survive on the stainless steel for 48 hours, on plastic surface for 72 hours. So we need frequent disinfection of personal items and OR environment in addition to hand hygiene. For N95 mask, closed facial fit is important. Each time the N95 mask is taken off, the wearer must double check that it is not been soiled or damaged before donning it again. Also consider placing a simple surgical mask on top of the N95 to prevent cross-contamination. Powered air purifying respirator, PAPR, is preferred for long-time operation if available. For surgical mask, consider double or multiple mask technique and proper tight fitting. Generally, surgical masks do not provide complete protection from germs or other contaminants because of loose facial fit. Therefore, it is not recommended in performing aerosol-generating procedures for suspected or confirmed COVID-19 patients. So, do we need to wear PAPR in all patients during this pandemic crisis? For green patients who is negative COVID-19, surgical mask will be fine. For yellow patients, suspected COVID-19, or for orange patients, for patients with a positive COVID-19 but no airway procedure, yellow mask will be fine. For red patients, positive COVID-19 and airway procedure, we need a PAPR or N95 respirator. Care for suspected or confirmed COVID-19 patients, protective eyewear, gowns, and gloves are needed. Donning eye protection equipment is recommended because inoculation of conjunctival mucous membrane is a mode of transmission. So, surgical hood with ties can be used for head and neck covering during aerosol generating procedures. Non-sterile disposable level 2 gowns are appropriate for use by providers during routine COVID-19 patients care. However, level 3 gowns are needed for surgical and aerosol generating procedures. Double gloves are recommended when handle COVID-19 patients. The proper way of donning is important, but the way of doping is paramount because we are already contaminated with the virus, so we need hand hygiene between each steps. What about OR settings? We arthroplastists are familiar with positive laminar flow, but if there is no outlet, it only makes viral lapse in a wind tunnel. We need negative pressure equipment in positive COVID patients. Overall setting is very similar to the basic principle to prevent PJI. Anesthesia and specific operative risk issues are all related to avoid generating aerosols because COVID-19 is an airborne disease. This is infographics for principle of airway management in suspected or confirmed COVID-19 patients released from Chinese University of Hong Kong. The rule of thumb is regional anesthesia is always recommended over general anesthesia, and when using regional anesthesia, the patients must always wear surgical mask. Nasal oxygen should be administered under the surgical mask. Face mask ventilation, open airway suction should be minimized as possible. Awake intubation technique, high flow nasal cannula, and positive pressure ventilation should be avoided. What about operation technique? For electrocautery, the setting and dissection time should be low as possible. In conclusion, we arthroplasty surgeons still have some roles in this pandemic crisis. So let's do our job. Before procedure, we need to decide which procedures can be performed. During procedures, we should be cautious to select personal protective equipment, anesthesia, and surgical technique as well. Thank you. God bless India.
Thank you, Professor Baik. It was an excellent presentation for safeguarding the patient and staff during this procedure in this COVID time. So, Professor, we'll have a question answer later in the discussion. And now we can invite Professor Zhu. He will present the lockdown experience, practice, how it has changed in Wuhan. So, Professor Zhu, are you there? Yes.
Yes. Hi. Thank you for your invitation, Professor Mohandi.
Welcome.
Can you hear me?
Yes.
Yes, we can see.
Can you see the slides?
Yes.
Okay, I will continue. I'm Wei Huaxu from Wuhan. Today I will share with you how did our orthopedic practice change during lockdown. I am okay. I come from Wuhan. I think everybody knows Wuhan from this year because Wuhan is famous because of the novel coronavirus makes Wuhan famous. Please allow me for a brief introduction of the Wuhan. Wuhan is in the center of China. This is Wuhan. Wuhan, the Yangtze River runs through the Wuhan city, and it has 11 million people. It has a lot of water. Can you see? So has a very beautiful places. The novel coronavirus is originated from the Huanan seafood market. Just nearby of the Huanan seafood market is a Hankou railway station. So during the Chinese New Year festival, a lot of people come and go through this railway station. Our hospital is just 4 kilometers away from the Huanan seafood market. It takes only 10 minutes to go from the Huanan seafood market to our hospital. So our hospital is at the epicenter of the pandemic. So this is a timeline in Wuhan. On December 1st last year, first confirmed case was reported. On January 20 this year, government confirmed COVID-19 can be transmittable between people. And on January 23rd, government announced Wuhan on lockdown. So, and also this period is the beginning of June 23rd is the beginning of our Chinese New Year holiday. This holiday is extended to the February 10th. It makes the longest holiday in the history. On April 8th, Wuhan reopened. Before January 20, because there's no evidence that the COVID-19 can be transmissible from people and people, so our work routine didn't change. After government announced the COVID-19 can be transmissible between the people, so everyone was required to wear facial mask and check temperature before entering hospital. We were asked to report patient with fever, cancelled the elective surgeries, encouraged patients to go home, assign patient to the separate ward room as possible. Outpatient department was opened as usual. Fewer patients go to see the joint doctor in the hospital because they are afraid of being infected by COVID-19. At the beginning of the lockdown, outpatient department was closed only for the emergency department. Only a few patients stays at hospital. Most of them they are from the other cities because the lockdown of the Wuhan city, the patient cannot go out of this city, so the only choice is stay in the hospital. We cancelled all the elective surgeries. During lockdown, we only accept emergency patients to the quarantine rooms. Then we perform the chest CT, iron test, antibodies. If the test were positive, the patient would be sent to the assigned hospital for COVID-19. If the result is negative, so the patient stay in our non-COVID-19 patient zone. We give the patient suggestion that conservative management was the first option. At the end of the lockdown, we accepted emergency and urgent patients to the quarantine rooms. We also performed the CT, IAA, antibody test. If the test was positive, the patient still will go to the assigned hospitals for the COVID-19. The patient without symptoms, we will have the RNA antibody test every week in the quarantine room. If all the test was for the COVID-19 was negative, so the patient can be transferred to the orthopedic ward room. We did do a few hip replacement surgery for the femoral neck fractures. We wore level 2 PPE when we inspected patients and did the operations. This is our protocol for our hospital protocol for the infection control. We reduce the volume of the patient in our facility, established a non-COVID care zone for the screening, temperature checking, and pre-operative waiting areas. Minimize time in waiting area, space the chairs at least 6 feet apart, and maintain low patient volume. Limit one family member accompany. They also do the pre-screen in the same way as the patients. This is a workflow for the orthopedic outpatient in COVID-19 during the COVID-19 pandemic. This is also the workflow for the surgical patient in COVID-19 pandemic. Thank you so much.
Thank you, Dr. Zhu. I think it's right from the horse's mouth, from the Wuhan, and it is really nice to know that you are working very close to the epicenter. And we'll have from the other part of the world, we have a Dr. Michael Gillespie from Australia, and he's going to talk with us the response from Australian Orthopaedic Association during the lockdown. So may I have a Dr. Michael?
Thank you, Sanjeev. I'll just share screen. Click here to start sharing the screen. Right. Can everybody see that, I hope? Good.
Yes.
So, firstly, thank you to Professor Mohanty and to Professor Sanjeev for thinking to include the IAA. We're very grateful for the opportunity to share our experiences. I'll just start my timer so I run to time. There we go, start. 8 minutes. Okay. Let's see if I can get that to move forward. So, who is the IAA? We're the peak professional body for orthopaedic surgery in Australia. We're responsible for selection and training of surgeons through our IAA 21 program, which is run in conjunction with the Royal Australasian College of Surgeons, and we train orthopaedics under the terms of a service agreement just recently renegotiated. Our other responsibilities are administering the Joint Registry, the Research Foundation, and AORA, which is the Registrars Association. Sorry, I've gone backwards. Again. What are our areas of interest are in education and training, advocacy, research, leadership and professional standards, and charitable works. These are our key roles. What have been the effects of the COVID-19 pandemic? Well, the first thing to say is that we haven't had the overwhelming rush of multiple patients. We've had our issues, that's for sure, but wearing strictly my AOA hat and not my clinician hat, I'll tell you how the AOA as an institution has tried to manage. First of all the face-to-face registrar teaching has been suspended, and it's mentioned later in the presentations, but it's also true that things like outpatient clinics, they're all been held on hold or put on hold. All the meetings that we usually sponsor have had to be cancelled and as a face-to-face encounter and be rescheduled as online activities. But all the things that AOA normally runs, federal and state scientific meetings, continuing orthopaedic education meetings, all the subspecialty society meetings have had to be suspended. And this is a big revenue stream for us, so we've lost a lot of money. Well, we've had to forego, we haven't lost it, but we've lost the opportunity to collect revenue. At the level of the coalface, all hospital level teaching and clinical review sessions have been cancelled and outpatient clinics are cancelled. For our registrars, there are normally 2 sessions a year where final examinations for fellowship of the Royal Australasian College of Surgeons are conducted. The May session had to be cancelled, which was tricky. If we move on to advocacy, how have we done on the advocacy front? Fortunately, we have very well established relationships with all the key players in health generally and surgery. We maintain a very friendly and collegiate relationship with the RACS. All AOA members are members of the College of Surgeons, but we are, as they would say in Latin, primus inter pares, or we are first amongst equals. We're surgeons first, but we're very definitely orthopaedic surgeons as well, and we maintain a friendly but independent relationship with the college. We have over the years developed excellent relationships with state and federal health departments. We have a very strong connection with the current Federal Health Minister and the Commonwealth Chief Medical Officer, who led the way for the whole of nation response for Australia when we faced the arrival of the COVID-19 coronavirus in our country. We've also had strong relationships with the orthopaedic industry, and we've had regular meetings about which I'll speak a bit later. The net result of all these things is that AOA is seen widely as the principal reference point for expert advice on any orthopaedic matter, including management of orthopaedics in the COVID crisis. AOA is seen as the go-to body. As for professional conduct and standards, this is a very sensitive issue with our membership. You'll see a little later in the presentation that when all elective surgery was suspended, it meant that virtually all arthroplasty was suspended, and regrettably, there are always people who are prepared to push the button and interpret limits creatively to their financial advantage. And so AOA ended up fielding a lot of complaints from members about what they saw as inappropriate surgical activity from their colleagues when they were meant to be locked down with the aim of preserving staff and PPE. A small number of matters have been referred to professional conduct and standards within our organisation. The effects on research and outreach, or orthopaedic outreach, is an independent body, but we administer it and we support, we offer them infrastructure. It's a charitable body, it's voluntary. That regrettably has had to be suspended indefinitely. But research, fortunately, has proceeded mostly uninhibited. This is the way things played out in Australia. The Prime Minister issued this statement on 25th of March. These are the three categories that were into which people were seen to fall. It's a view of the Orthopaedic Association that these are extremely generic, and they're not specifically well suited to describe a lot of painful and disabling orthopaedic conditions that may not necessarily meet Category 1 or Category 2, but which are nonetheless just on the basis of common humanity and simple relief of suffering, worthy of treatment earlier than the restrictions allowed. But the ruling came from the top, so however imperfect this system was, that is what we are required to work under. The net result of all that is that, there's a hair trigger on my mouse. For the couple of weeks before the announcement by the Prime Minister on the 25th of March, public elective surgery was pretty much put on hold in advance of this announcement, and it became definitive across both public and private sectors from March 25. How did the AA respond to this? The first thing we did was to establish a risk management working party, which started at the beginning of March, and it was not exclusive. We cast the net very widely, and all people who interacted with us and all members of our association and subspecialty societies were invited to join. We had weekly meetings, and that is telling me I've got to hurry up. We had weekly meetings and then fortnightly. Included in this meeting was meeting with an association called the MTAA, Medical Technology Association of Australia. It last met on 27th of May. Let's go ahead, that's the same slide. The second arm of the response was to develop a specific go-to site on our website, which included a member information page and a member forum. This is a snapshot taken off my own computer of that web page. I'm sorry I edited it out, but you can see there's an information site for patients, for members, And the next thing we had was position statements. These were worked up by members of the subspecialty societies to provide advice for patients in the non-operative management of orthopaedic conditions while elective surgery was on hold. There's one for knee. This is a general statement that tried to explain the orthopaedic positions. All these are accessed without to the public part of our website. This is the advice we offered to members and to trainees. I highlight for you the member forum, which is a very useful place for members to decompress and raise concerns and queries and get rapid feedback. The last thing we did was ask all the members of our subspecialty societies to produce position papers on what the suspension of elective surgery meant for their particular subspecialty. This is an Arthroplasty society, so I reproduce here for you. These are all the various subspecialty societies: shoulder and elbow, spine, knee society, foot and ankle, and you can see it there. This is the Arthroplasty Society of Australia, which I think most closely parallels your organisation. This is how the Arthroplasty Society invited members to interpret the restrictions on their surgical practice. So we tried to do our best to give people as much advice as possible. And this is the same things, same two slides in a little more detail for those whose presbyopia is a little more challenging. I've gone over my time, so I'll stop there and say thank you for your attention.
Thank you, Michael Gillespie, and I think you have given really a broad overview of how the Australian Orthopaedic Association is going about responding in a different aspects in this COVID-19 situation. Before we have it, there are 3 questions on the panel, but before we start those question answer, I would request our Indian faculty if they would like to have any discussion or question with our international faculty. So maybe Dr. Maria, would you like to?
I think it was very well summarized between the 3. Practically everything's been said, but a couple of things. One is that what would be the precaution, because in India we are slightly different. We have people staying with the patient or there is an attender. It's very difficult to tell them not to be there at all. So if you have one person, what would you be your test protocol for that person? Secondly, what would be the testing protocol for the operating room staff and both the medical as well as the paramedical staff? Would you test them with the PCR or the antigen or whatever test you would do? And what would be the periodicity of those tests?
So, Professor Zhu, how are you following this in China and Wuhan?
According to the government regulation, we are mandatory to test RNA antibodies for the COVID-19 and also the chest CT scan. They go to the hospital if they want to admission to the hospital. This is mandatory. If the patient refuses, we don't do the patient cannot go into the hospital, into the inpatient department, and cannot perform the surgery for him.
What about the patient attendant? Suppose there is an attendant with a patient. You also test for the patient relative who is coming with the patient?
We only allow one relative accompany the patient. They also perform the same test as a patient.
And what about the operating room personnel, your nurses, operating room attendants? Do you test them in interval, like weekly or in every fortnight?
Yes. The attendant in the operation room, they only test before go to the work, before the reopening. Then, if we don't have the fever, we don't retest. if we have symptoms, we will test it.
Okay.
We have a question from Dr. Partha Sathi, and he's asking, apart from standard COVID protocol, is there any special precautions at the time of doing an arthroplasty surgery? So may I take this question from the Michael and Beck, Professor Beck? We can't hear you, Michael. You have to unmute.
Yep, just unmute. So I'm just trying to see the question again.
Okay. So apart from the standard COVID protocol, are there any special precautions doing the arthroplasty at this time?
In Australia, we've been blessed with a very low clinical load of COVID positive patients compared to your vastly more complex and populous country. So our protocol, those that Dr. Zhu and Professor Beek have described, that is the approach that they've described is pretty much what has been adopted in Australia. We have not varied from that.
Well, fortunately, we Arthroplasty surgeons are very familiar with the basic protocol to prevent PJI. So most of protocol is really good to prevent, diagnose, and treat COVID-19 patients, except negative pressure operating room system. So I don't think that there's some additional special attentions we have to put attention except besides my presentation.
Okay. So Dr. Bharat Modi, sir, would you like to have some interaction with the faculty?
Indeed. In very important difference between the three esteemed guests who are giving their experiences and protocols that they adopted in their countries, there is a very significant difference between their practice in this pandemic situation as compared to a significantly large proportion of healthcare delivery as it exists in our country, say in India for that matter. I presume that most of the hospitals in South Korea and in China especially are probably supported heavily by government funding and healthy government funding. Probably in Australia, they would have hospitals which are not necessarily supported everywhere by government funding, but either way, whether private, trust or government, they would have healthy funding. Against that, in India, broadly speaking, we have two separate segments. One is government funded hospitals, which are extremely stretched in monetary requirements to handle even the routine, practice of medicine, let aside this pandemic situation. And then we come to the private sector. And in the private sector, we have broadly speaking two categories. One is hospitals like where Dr. Maria works, or for that matter, Dr. Jain works, where they are supported by large corporate entities. And then comes to people like myself, who are entrepreneurial type of doctors, and depending upon their own strength, they would have created healthcare platforms which are completely owned by them. The business pressures of adopting any of these protocols are also have got to be factored in as they develop their own protocols. Given this understanding, let me tell you what I have faced. I own a 100-bed facility, which by Indian standards would be called a medium-sized hospital in the private sector arena. Or smallish medium, let me put it this way. But it's a professionalized platform, 100-bed with an employee strength of about 250 people put together. Now, and I am the main chief surgeon, also the CEO and the entrepreneur who has to look after the profit and loss account of the establishment. The challenges which this pandemic has thrown at people like us are incredible, and their forces are of a seismic proportions. And I'll explain to you what I mean by that. we just saw a very superbly evolved protocols, which Dr. Zhu, Dr. Beck, and the two of them put forth to us as to how to go about adopting our practices in the OR and outside the OR in our hospitals. What are the challenges? A disposable PPE to be provided to a large number of hospital staff on a daily basis. It adds to the cost. A country like India, where the cost sensitivity is so huge that patients are not able to take on those costs. The government, in its socialistic bent of being politically correct and acceptable solutions, has enforced artificially low price caps for treating or charging patients for anything to do with COVID. Okay. Given these scenarios, the fact of the matter is that a lot of us will have to find our own middle path, the path of the Buddha, I would say, that allows us to adopt a reasonable level of security for the patients, for the hospital team members, it's right from surgeons to the stretcher pushers. Lastly, to ensure that we are able to practice, at least in a low-key manner, in a less way, but practice our art of arthroplasty so that not only patients benefit, but we as surgeons and people who depend on us are allowed to continue their way of life, their earnings. For example, what we have done, the first 2 months were a shock, and we had no option but to absorb the losses and almost come to a complete halt, because especially my hospital is an elective orthopedic hospital. It does not deal with COVID, it does not deal with other types of medical problems to speak of. So we came almost to a complete stop. Revenue was zero, patient activity was zero. Because of government orders, we continued to pay our staff members from internal accruals that had happened in the past. After 2 months, we realized that irrespective of what the government might say or might not say, we will have to do some cost rationalization. So what did we do? We made most of the staff members come on alternate days so that we don't lose out on a collective skill set which has been built over a period of years as a result of those team members having stayed with you for so many years. And now, in the last 1 month, 1.5 months, I would say, we opened up our hospital for elective arthroplasty surgery and arthroscopy surgery, along with some trauma surgery as well. And what have we done? We didn't have to struggle because
can we discuss this in the last session, if you don't mind?
Okay, sure.
There are a couple of questions there. Okay.
I will conclude that.
Yes.
So
we have a
I will just conclude them.
Yes.
Go ahead, Sanjeev.
No, sir. Conclude, please.
No, so I just conclude by saying that as and when the right moment appears in our discussions, for a lot of people who are looking at something what I am saying on those lines, we should come out with some practical solutions which are not necessarily exactly as per the standardized protocols, but which give you a balance between practicality of finance, of practicality of actually being able to do it, and also maintain a margin of safety which allows you to move ahead with life. So please, go ahead, Sanjeev.
Yeah. So there's another question, and which says that Professor Beck, basically it's to you, that do you recommend using PPE kits for circulating staff and assisting personnel during the positioning and all other work inside the theater during the surgery?
So that's totally dependent to the patient's case, and the patient is COVID negative patient. That means the patient is a green state and green patients. Even surgeons, operating surgeons don't need to wear full PPE. Including PAPR. For green patients, just wearing surgical mask and routine attire will be fine. But if COVID-19 positive patients, actually the patient is not the indication for arthroplasty in this pandemic crisis in phase 2 or 3.
Okay.
Professor Beck, may I ask you a question?
Sure.
Sanjeev?
Yes.
Yes. Prof very rightly suggested that the operation theatre infrastructure should now turn from positive to negative pressure operation theatre air circulation systems, especially if those operation theatres are going to handle COVID dirty or COVID positive cases. Now,
Yeah, right.
the problem is it easy or practical to turn a positive engineering infrastructure designed for a positive pressure facility into a negative pressure facility? I mean, how much of a challenge is it even for a country like yours and hospitals like yours?
So actually, we exchanged one operating room into negative pressure, and the pressure, positive and negative, is not different way, because even in negative pressure system, the laminar and positive pressure continue to keep going on, and the only difference is to make outlet. I mean, the positive air can flow outside. So we make some flows from the sill to the window. So can you understand? So it's not negative pressure system does not mean observe all airs to the ceiling. It's a different one. So there's a still.
I know what you mean then. I understand. What you are saying is 100% evacuation of the air. So you open up your dampers of your system so that the air that comes into the OR is then evacuated completely. So it's a bit different from what a negative pressure system would be, but I understand now what you mean by negative pressure in your slide. Thank you.
Okay.
Okay, so there's another question. After a negative RT-PCR test, okay, you should wait for 5 days and repeat and then operate, or immediately after negative test you can operate?
Usually it takes 4 hours in South Korea.
Okay. So if you have one test which is negative, you straight away operate, right?
Yeah, in the very beginning, because we don't have any evidence for false positive or false negative. So, at that time, if we have to perform emergency operation, we always think this patient is kind of considered as suspected patients, classified into suspected patient, even the result is negative. But now, we believe the accuracy of the PCR test, and if the patient has no symptom and the test result is negative, we consider the patient does not have any coronavirus at this moment. So just perform surgery as a routine procedure.
Okay.
Thank you so much. I have a question for Professor Su and Professor Baek, both of you. Which of the two tests would you consider more sensitive and specific for diagnosis of COVID positivity, the HRCT or the RT-PCR?
Thank you for your question. I think for the earlier time, because of the false rate of the INA, we prefer for the CT scan. When the case is going down, we prefer the RNA test.
Yeah, but that's because of the volumes. But which is the more sensitive and specific for the diagnosis? The HR of the CTs of the lungs, or is it the RNA test? Which is more sensitive or specific?
I think
both.
If the patient has the chest X-ray, that means he has already infected with kind of I think it's in the middle of the disease. And at the beginning, we need the RNA test.
But there is a 30%, sorry, Professor Baek. There is a 30% patients, there is a possibility of a false negative test with the PCR, RT-PCR. So if you take CT scan and RT-PCR together, what is the percentage of false negative that will have at risk of taking those patients?
Right, but actually, well, I asked the same question to the physician in my infection department, and he told me RT-PCR is very accurate test, and actually, and it's dependent to the quality of test. So maybe the test quality is different from country to country. So the reason why Koreans does not perform CT is the very high accuracy of RT-PCR in South Korea.
Okay.
Because we already performed 10% of South Korean. I mean 10%, 1/10 of people in South Korea already experience RT-PCR. That means a lot of samples, and the technician already experienced and trained enough.
Okay. So, Professor Mohanty, I think we can move to the next session because of lack of time as well. It's a wonderful first session and the nice discussion amongst the faculty and the questionnaire.
Sanjeev, can I add something to what Dr. Mohanty asked?
Yes, please.
Yeah, I went through this, slight amount of study as to, when we were making protocol for our hospital. And we realized that RT-PCR is very sensitive to how you take the test. And that is why in our country, when, a lot of our technicians are also afraid of going to these patients. So the false, negative is very high. We are only hitting at 60% positive rates. We are missing actually, 40% people who are positive, but we are not actually getting because of the fear of the person who's going and doing samples. So, and the studies which came out even from the European studies, if you just rely on RT-PCR, you are 65% accurate. You do 2 RT-PCR, you hit a bit more. If you add CT chest to it, you are 99. So 2 RT-PCR and 1 CT chest, 99% accuracy. So if you want to be ethically, strong and financially sound, that's the way to go. But, none of the hospitals is going to allow you that. The only question we have to ask is, as we asked Dr. Baek, should we do 2 RT-PCR or should we just rely on 1 and go ahead? Currently in our hospital protocol, just 1 RT-PCR and asymptomatic patient, of course.
I think that's perfectly fine, and that's what most of the people are doing, 1 RT-PCR. But there are patients when we have seen that asymptomatic and RT-PCR negative, even the X-ray, the CT scan shows the COVID lesion, and they have been considered as a COVID positive patients.
Yeah.
So may I request Professor Zhu, post-lockdown situation, the resuming orthopedic practice after lockdown, step for gradual reopening. So, Professor Zhu.
Thank you.
Can you please share your screen and unmute yourself?
Sorry for the... Sorry for the... hello, can you see the slides now?
Yes.
Can you see the slides now?
Very well.
Okay, thank you. So this time I will share with you about resuming orthopedic practice after lockdown. Steps for the gradual reopening. So Wuhan reopened on April 8th, 2020. Current status was 0 case in Wuhan. The 0 newly confirmed case found in Wuhan begins on March 21st. There were several newly confirmed cases in May. So we don't have any suspicion case or confirmed case of COVID-19. Before the resuming, we were asked to report our temperature every day. Medical staff were tested to rule out COVID-19 infection before coming back to work. All the ward rooms and operation rooms have been sanitized. So when to resume the orthopedic elective surgery, just as a joint replacement? Regional health system became seriously stressed when regional bed or ICU bed availability drops below 20%. So when the hospital bed, ICU bed, ventilator availability exceed 20%, so we are ready to resume joint replacement surgeries. At the beginning of the resuming, temperature check for everyone in the hospital, both include patient and medical staff. Our outpatient department was reopened on the April 8th. We wore level 1 PPE and kept social distance from each other. Only COVID-19 negative patient can be admitted to the inpatient department room. We also limit one accompanied family member. The family member and the patient, both of them, performed chest CT, RNA, or antibodies test. This is a guideline of our hospital for the orthopedic elective surgery. Comply with all the guidelines to protect against further spread of the COVID-19. Institute screening of the healthcare staff for the symptoms of COVID-19 and have a policy in place for removal of symptomatic employees from the workplace. Enforce social distancing requirement in the working area and common areas. Require mask for everyone. When possible, set up non-COVID care zone in facility. Have an established plan for the cleaning and disinfection prior to use the facility to serve non-COVID-19 patients. Facilities provide COVID-19 care should be continued to be prepared for the possibility of future surge. This is our pre-surgery COVID-19 test. So the body temperature, negative COVID-19 test both include both INA, RT-PCR or antibodies. Normal chest CT scan. Test each patient before admission to ensure COVID-19 negative status. To control the infection of the COVID-19, we reduce the volume of the patient in our facility. Established a non-COVID care zone for screening, temperature checks, and operative waiting areas. Minimizing the time in waiting area. Space chair at least 6 feet apart and maintain low patient volume. Limit to one family member accompany. So when Wuhan is opened, we gradually open more. So temperature check for everyone in the hospital is always. We set quarantine zone for newly admitted patient. At first, we need the patient to stay quarantine zone for 7 days, then decrease to 3 days, and then to 1 day. So transfer to normal ward room after second RNA test was negative. Operation room was sanitized between the two operations. At first, we need 2 hours to disinfection the operation room. Then we decrease to half an hour. Now we back to normal. We didn't have the space suit for the joint replacement surgery. We wore level 2 PPE to do the operation at first. So we found it was unnecessary. and it was very difficult to operation because we always it's very easy to contaminate the operation instruments, especially when we wear shields. This is extra precaution for the orthopedic inpatients. We wear masks all the time. Take body temperature at least 3 times a day. Test antibodies every 7 days. Limit one accompanying family member. Transfer the single room when necessary. Nowadays, we resume all the elective surgeries. Only IAA and antibody tests are needed before the patient administration. We don't do chest CT scan anymore nowadays. We still allow only one accompanying family member. The family member still needs the IAA and the antibody test. Temperature check for everyone in the hospital. Antibodies needed to be tested every 7 days. Now we are only level 1 PPE when we inspect patients and doing the operations. Thanks for your attention. God bless India.
Thank you.
Yeah, so thank you, Dr. Zhu. And we'll request Professor Baig for his talk on apprehension and expectation from the patients after the lockdown. I think this is the most important issue remaining, because the stress level with the patients, even in the healthcare worker, is very high. So let's listen from the Professor Baig.
Okay, can you see my slide?
Yes.
Yeah, okay, I will go. Yeah, right. That's a very important, issues, but it's also, not easy, questions to answer. The uncertainty of understanding of pandemic behavior and definitive ways for its prevention cause psychological pressures on both patients and healthcare providers. Recent surveys show that 1/3 of patients are willing to wait for at least 3 months after restrictions are lifted to seek care, and 1 out of 5 will not feel comfortable returning for procedures until 6 months have passed. However, the panic and fear of getting infected can be increased. The unnecessary burden and use of healthcare services, and moreover, sometimes life-threatening. Thus, the surgeons should be fully aware of psychological pressure on the patients and their families, and open communication may help elevate some of these apprehension they feel. Thus, we should fully understand the psychology pressure on the patients and their families. This is an example of a toolkit for discussion with the patients to help surgeons and hospitals to address patients' concerns, which was a list from ACS. If you visit the website, you can find suggest questions. These questions are very practical, and you may encounter them from your patients. Depending on healthcare providing systems, the answer may be different. What can I expect when I arrive for appointment in terms of COVID-19 protective measures? In my hospital, some entrances were locked out for your safety, and you will be requested to write down your name and phone number, or you can enter hospital number into the computer, or use your own smartphone application. Will I be with others in a waiting room, or will I be kept in room away from other patients? Please keep social distance more than 6 feet in the waiting room. Do I need to wear a mask? No entry into the hospital. Will there be physical barriers? Yes, you may talk to the reception across the plexiglass. Will I be tested for COVID-19 and have my temperature taken before my operation? Sure. The day before operation, if you have fever, your operation can be postponed. Will I be taken into other areas of the facility for testing or exams before the operation begins? Most of preoperative evaluation were already performed on outpatient basis. Who are all the people I can expect to interact with at the facility? You will contact medical staff dedicated to you, and they will be wearing masks. If you have difficulty to listen, they are willing to write down to make it clear. Also, we have video clips for your help. Are the staff members I encountered also treating patients who have COVID-19? Nope. Dedicated medical staffs were assigned to care COVID-19 patients only in different buildings. Will I be close to others if I walk through the hallway or other common areas? Only a limited number of authorized people can enter the ward, and they are wearing masks. I believe you can make your own answer to these questions. What special precautions are being taken to ensure the operating room is safe from the COVID-19? There are lots of more questions. How has the facility determined that it's not now safe to begin scheduling operation? How is the facility disinfected, and how often? Is everyone who works at the facility having their temperature taken and being tested for COVID-19? The answer may be no temperature check, no starting to work every day. Does the facility have enough personal protective equipment for the staff? Fortunately, yes. You don't need to worry about this at all in my hospital. As I recover, will having this procedure put me at a higher risk of getting COVID-19? No. If arthroplasty put you at higher risk of getting COVID-19 after recovery, we should have not scheduled your operation. Will the presence of COVID-19 in my community change how long I stay in the facility following surgeries? Yes. We already reorganized the clinical pathway to shorten your stay, but don't worry, your clinical course won't be changed. Can I have visitors while I recover? That's up to you, but you can meet only a limited number of visitors one by one in the designated place with social distance, and wearing mask is mandatory. You can make your own answers to off-site care questions after next session. However, all of these questions are kind of closer discussion. You can only answer when the patients may ask something to you. Instead, open communication will help alleviate some of the apprehensions which the patients may feel. Moreover, they can reach out to patients directly who may also have wanted to reach out to you but are not comfortable making the first phone call. You can use a press release or social media like Twitter, Facebook, or Instagram. You can make video clips or newsletters showing what the patients can expect when they enter the facility, high level of summary of the measures that your hospital is taking, or patient success story. You post them later on your hospital website. So please be prepared to listen to the patients carefully. You are the most powerful voice for your patients who are wondering whether their care will be safe. Use press release, social media, video clips, or newsletters. Special thanks to all medical staffs in front. Thank you.
Thank you, Professor Vic. That was an excellent exposition of the apprehension of the patients that what usually we face in our day-to-day practice. So we'll have a discussion later, and can you stop sharing your screen? Then I would request Dr. Gillespie to take his final lecture on new normal in orthopedic practice post-COVID-19, telemedicine, safety measures, etc. Professor Gillespie, please. You have to unmute yourself. Dr. Gillespie, you have to unmute yourself.
We cannot hear you.
We cannot hear you, Dr. Gillespie. Anand, can we unmute Dr. Gillespie?
You have to unmute Dr. Gillespie yourself.
Still we are not able to hear you. Mike.
So open your BlueJeans application. On the top you can see.
How much is your percent? There we go. Good. I hope you can hear me.
Yes, we can. Yes.
Sorry about that, guys. Yeah, just try and get that going. Hang on. Okay. No, share screen. There we go. How's that? Is everybody got me
Looks
now?
great, yeah.
There we go. Apologies. I'm a bit of a BlueJeans is a new application for me. I'm sorry.
For all of us.
Okay, so this is a little more administrative rather than clinical. Australia is a very large island with a very small population, and we live at the bottom end of the world. There's only New Zealand between us and Antarctica, and New Zealand have certain economies of scale being pretty large and even smaller. So my talk is more administrative than clinical and practical, and if that's not quite the theme of the meeting, then I apologise for misreading the mood. But what are the implications for AOA going forward now that COVID-19 is amongst us? We have been obliged, by virtue of the fact that many of the meetings that we run across all forums are a profit generator for us. We've had to reinvent ourselves, and we are now partnering with industry to create virtual meetings, which and the trade-off is that for a fee, industry can present directly to our membership. So we've lost. There's money that we will lose that we won't make up for a while. So the upshot of it is that AOA has moved to embrace a digital future, which was already part of the plan, but we've done it on a much faster basis. So that means that a lot of the meetings that used to be face-to-face that involved travel and airfares and accommodation are now conducted by conference forums like BlueJeans, Zoom, video, WebEx, GoToMeeting, and so on. That's proved surprisingly good, and we will probably continue that long after a management strategy for COVID has arrived at. So that was for AOA as an entity. For individual surgeons, we have tried to provide information for our members and via our website, and we've taken education online with a lot of free webinars on all kinds of technical subjects, hand surgery, spine surgery, and then managerial matters such as managing unconscious bias. So webinars will be the way of the future. For our trainees, the face-to-face sessions have declined to virtually nothing, though that's starting to pick up. However, moving our teaching sessions and lectures online has been very well received. It is a major logistic exercise for us to manage our candidates hoping to sit and pass their final fellowship exams. There's normally 2 sessions a year. The May version had to be cancelled altogether, and now the October session is under threat now that there's a second wave in Victoria, which is traditionally where the exams are conducted. So that is testing the ingenuity and the creativity of the Board of Examiners. There's a flow-on effect for trainees in that they are all hoping to travel to do post-graduation fellowships, particularly those hoping to travel overseas. The traditional rite of passage for Antipodeans is to migrate to North America or to UK or Europe for further advanced training. That, of course, is an impossible dream at the moment. So those logistics will have to be worked through. The upside for our association is that the local fellowships, which are traditionally offered to overseas candidates, are now going to be filled by local candidates. There have been some significant impacts for patients. Elective joint replacement has been delayed in public and private. The outpatient clinics are now only slowly returning. On the upside, we've been able to switch to telehealth and telemedicine very quickly. The federal government very quickly, for large ponderous bodies, has very quickly adjusted the Medicare system, which is the national public health kind of default position. It is now possible for doctors and patients to interact via mediums or media such as the one we're on now, or via telephone. A lot of routine follow-up and even preoperative consulting can be conducted at distance. So telehealth has generally been a benefit and will probably be retained beyond this crisis. The same applies for virtual fracture clinics and preoperative subspecialty clinics such as paediatrics and joint replacement. Certainly follow-up in the case of the latter can be run very effectively through telemedicine. We are slowly embracing, because our numbers are so small, as you're aware, Australia is a very large country with a very small population, mostly collected in 6 or 7 large urban hubs and then very low population density elsewhere. So certain elements of geography and population density have worked in our favour. So preoperative COVID testing is now only required, it's required for all surgery in Victoria. It's not yet required in any other state, as far as I'm aware. PPE supply chain availability is an issue. At the moment we are coping, but with rulings from President Trump that all the best quality high-level PPE made in America has to stay in America means that the quality of the stuff we're able to obtain here in Australia has been variable. But for the benefit of those who probably haven't followed it closely, Australia's engagement with COVID-19 is intensely regional. Most of Australia has vanishingly few cases. Tasmania is insular by geography and disposition, and Tasmania has closed its borders to everybody. Any native Tasmanian wishing to return has to go into quarantine, and the same applies for Western Australia, Northern Territory, and to a lesser extent Queensland. ACT, or the Australian Capital Territory, where I live, is a small landlocked island in the middle of southern New South Wales. The border to our south is now closed, and it's a hard closure. It's still possible that we'll be contaminated by a few cases wandering down from Sydney, which is only 3 hours up the highway. Hard border closures between Victoria, New South Wales, and that includes ACT, even though we've had no cases in the last 28 days. It's very hard to get out of New South Wales or Victoria into anywhere else in Australia. New South Wales is currently ticking along with very small numbers, but it could go ugly. Victoria is absolutely well and truly experiencing a second wave of infections for local decisions that need not trouble us now. They're even out at around 400 to 500 a day, and they are in very, very hard lockdown as we speak. They can't go anywhere or do anything. All elective surgery is suspended. And amongst many worrying signs is that an increasing number of healthcare workers are starting to become infected. So the worst of all possible scenarios, where the health system is overwhelmed, remains a live possibility in the state of Victoria. Having said that, I thank you for the invitation to speak at this meeting, and I commend you all for dealing so professionally with a problem that, fortunately for Australia, we have not had to make the hard decisions that you guys have been making every day. It's a privilege to speak in your presence, and I thank you for your patience in listening to my rather unremarkable story. I wish you all well. Thank you.
Thank you. Thank you, Dr. Gillespie. So, Sanjeev, we can have the discussion now.
There are a couple of questions for the speakers. So there's a question which says that after how long, once the patient is turned COVID negative, the arthroplasty can be performed? One, and then what is the role of anticoagulant? Is there any change since the use of aspirin has been recommended more and more? So can you switch over to only aspirin or continue with the old protocol? With all the faculties, one by one.
Yeah, Dr. Jiu, please.
Yes. Thank you for the question. We don't have the exact time, but we test IAA. That means nowadays IAA test is very specific. So we test 2 times of negative result, CT scan and antibodies. We don't have any symptoms of COVID-19, so we can perform the elective surgeries, no matter how long he has infected. If the patient is infected, we still have the COVID-19. We postpone the surgeries for this patient. Thank you.
But how long? Any time limit that you don't know?
Because the COVID-19, some patients have a very long period of disease. I think some patients may last for maybe 3 to 4 months for the patient, but some patients only have this kind of disease only have a short period, such as less than a month. They recovered. We can do the operation. I think so.
And do you
not
give
according to the time, but according to the negative result of the COVID-19.
what about thromboprophylaxis? Prophylaxis for DVT. You give
prophylaxis for the DVT. It's the same. The protocol it's the same as usual. We give the heparin just after operation for the total joint replacement. We routinely give the patients anticoagulation after surgery.
Yeah, Dr. Beek, what happens? Many patients after recovery from the COVID-19 they're again coming back with a pulmonary fibrosis. That puts a risk of any major surgery. So in continuation to the same question, what is your protocol after the COVID-19 is recovered from COVID-19? When the patient should resume the arthroplasty?
So you mean the candidate has already COVID-19 infection?
Yeah, in the infection he has recovered. So when you do, what is the time period when you do arthroplasty?
Actually, I don't think we have such a kind of patients at this moment because, there's two groups. First one is a young person, and second one is because we have extreme ages, very young. Around 30, and the other is over 60. And high mortality in elderly patients are well known to recently, although we are afraid of a cytokine storm in young patients. So maybe I have no idea actually, but if elderly patients experience COVID-19 and have some lung fibrosis, I don't think she or he is the ideal candidate for arthroplasty within 6 months.
Okay. Do you have any preference to the comorbid conditions during this COVID-19? So how do you select your patient, and when you're coming to the normalcy, new normal, that how do you select your patients, which patient you will take as per the comorbidities? Do you have any priorities?
For arthroplasty, you mean?
Yes.
Professor Chang, you mean candidate for arthroplasty?
Yes, candidate for arthroplasty. So patient who's having comorbid conditions and patient do not have a comorbid conditions. Do you select versus comorbid or morbid conditions, or you just take every patient in?
So, there's two category of questions, but there's a lot of factors affecting the indication or priority for arthroplasty. So if the same one, but if young patients or the age does not usually affect the priority of for arthroplasty in my case.
Okay. We have a Krishna. You are there? Krishna Kiran? You there?
Yeah, I'm there.
Do you have any question to the faculty? Yeah.
So what would be the ideal time to resume elective surgery at all? Because wherever we are seeing, I think there is an issue regarding doing arthroplasty, because not only doing the surgery is an issue, but also perioperatively they are likely to be immune compromised or have an issue for next 4 or 6 weeks because of the surgical insult itself. So I would like to ask, what is the Wuhan experience with the patients actually undergoing surgery? Have there been higher incidences of infection, or there's no problem at all when they've resumed elective procedures?
Dr. Zhu, could you please answer?
Dr. Zhu.
I'm sorry, can you repeat the question?
Is there any problem to the... Whenever you resume elective arthroplasty post-COVID, there is still a theoretical risk that this patient post-operatively may contract the disease. Have you seen any such instances in your practice? And is the outcome any different now in the post-COVID scenario?
We don't perform the surgery for the COVID-19 patient. If the patient had, because the joint...
That's true, but post-operatively somebody can contract the disease. Correct, but somebody can contract a disease in the next few weeks. Have you seen any such patients? Because now it's an ongoing pandemic. You did a surgery and somebody contracted disease in the next month or so. COVID.
No, I don't have this such kind of...
No.
Sorry.
Can I?
Dr. Gillespie, any take on that?
No, I think once again I'm undone by relatively low numbers in Australia, and certainly in my city. Our numbers are almost embarrassingly small. I have no personal experience in operating on COVID positive people, and at the moment we are in the two centres where there are reasonable numbers. All those usual protocols are being followed, and we have the luxury, because our numbers are relatively low, being excessively cautious. So no, I think I'll stop now and say I don't think I've got any special wisdom to offer on the subject.
Any of the faculties have an experience operating on a patient who was COVID positive before and now it's negative? Any of Indian as well as our guest faculty, all?
Can I say something?
Yeah, Dr. Malik, please.
Now the point or data to lay down protocols in regard to operate on anybody who has had COVID situation. I think we will all have to form our own protocols, make our own timings and mistakes, or achieve something unusual. Currently, I think we are telling patients to wait minimum for 3 months. Who have just about started. We have had 3 patients who had COVID and who want this surgery. That's one. There was only one patient, but that was a hip replacement, who had just got out of COVID. So far, fingers crossed, the patient is fine. The DVT prophylaxis is essential because there have been so many hypotheses what happens, so many pathogenesis, what happens. One of them even talks about the vascular challenge and the DVT propensity. So for that, in any case, you have to take care of that. But now what my question is after this is that we have talked so much about the patient, we have talked so much about the environment, about everything, but what is the surgeon's medical legal liability if he operates a negative patient tested once and that patient contracts COVID a week later? That's my question. Where do we stand, and where, both in the medical world and in the court?
Correct. Dr. Beck, would you like to take that?
Yeah, that's a very good question. And at first outburst in Korea, we actually afraid of that kind of medical legal problem. Very afraid, but not all COVID positive patients can make others infected if he wears a mask and the doctor or professionals are wearing the mask. Actually, there's another story one of my patients was COVID-19. I performed arthroplasty maybe 8 months ago, and he he visited my outpatient clinic, and because I'm afraid of and suspect septic, because his original diagnosis was septic arthritis, but actually he contacted 4 nurses and 20 doctors and maybe 50 patients, and even but no one get infected after 1 day after admission, because he wearing N95 mask is mandatory at that time, even patients and family, and me also wearing the masks.
So how many of the faculty they take a special consent that the patient may get infected with COVID after the surgery? How many of us?
We do.
Okay.
But we do take, although I don't know whether it stands in the court of law and whether it makes me any less vulnerable, but I just do it as a matter of practice.
Okay. Dr. Hughes, do you take a consent from the patient that after operation there is a possibility of COVID positive?
The government, at the beginning of the pandemic, we do have one patient infected with COVID-19 after operation. So we transfer the patient to the assigned hospital for the COVID-19, treated as a COVID-19 patient, because the patient after surgery say it's very easy. He doesn't matter, because if we perform the arthroplasty, the patient hip joint is okay now, so we treat as a COVID-19 patient. Afterward, if we have found a patient with COVID-19, we don't allow to perform elective surgeries for the patient. If the patient has the emergency condition, we need to do operation. So during the lockdown, we transfer the patient to the COVID-19 assigned hospital to perform the surgery. We only perform the COVID-19 negative patient in our hospital.
Okay.
Thank you, Dr. Zhu.
Thank you.
So we have a different scenario here. We have somebody from Australia, somebody from Wuhan, somebody from Korea, but we have our gentleman here who is doing an arthroplasty, and I'm sure that country to country and also the setup to setup, corporate versus private, the differences are there. So we would like to ask our Indian faculty in a brief one by one, starting from Krishna, the guidelines once we start, okay, the joint replacement procedure after this COVID lockdown. What should be our strategy for our surgeons?
So we have some experience with that. So once the lockdown was lifted and the cases in the last 2 to 3 weeks were lesser in our area, we restarted elective operations. And we did quite a few of them till second week of June. And from second week of June, the cases started increasing, and slowly the hospital, which didn't have any COVID beds at all, became completely COVID. So in Hyderabad, all the major corporate hospitals have got entire hospitals converted into COVID facilities. So we don't have a non-COVID facility to do any elective surgery at this point in time. So that's the situation now for the last month and a half. So we stopped all elective work. Only emergency work is being done, that too periarticular fractures and hip fractures. So but I feel that guidelines are pretty clear. If there is a drop in the number of newly positive cases for the previous 2 or 3 weeks in that area, and based on the local governmental guidelines, we should restart elective work. So it cannot be unilateral. And then you should have a non-COVID facility to deal with these sort of situations. So if you're still continuing to admit COVID positive patients into the hospital, there's no point in resuming elective surgery, because it's very difficult to have separate areas for COVID and non-COVID patients, and patients also are apprehensive of coming to the hospital in the first place. So if you have a non-COVID facility, coming down numbers of cases, local governmental guidelines in favor, then we can restart with the patients with low comorbidities and younger patients, probably hip replacements in the younger patients, unicompartmental knee replacements, and patients less than 60 who are undergoing unilateral replacements. So that would probably be the way forward, and routinely test them with an RT-PCR and CT chest, and ask them to self-quarantine for a week after the test. And if there are no symptoms in that week, then they can come for the surgery. Decrease the duration of hospitalization. So maybe do a daycare procedure or send them in a day or two in a non-COVID type of facility. So that's what I'm looking at.
So what's happened in Kolkata?
Yes, Sanjeev, I think our experience has been very closely to what Krishna actually experienced. That in the month of June, we actually reopened, and we did lots of arthroplasties. But July, we had another major positive rates, probably due to more testing, I think, rather than because we were not testing enough. And the other thing which happened was because so many people became positive, our center was the only hospital in Calcutta which was not taking COVID patients. So we were actually a non-COVID patients from March, April, May. and even till middle of June. But then the government guidelines came that, we are just totally run down with COVID, and ours is quite a big hospital. So they said, you have to take COVID patients. And suddenly we had to open up about 100 beds for COVID patients. And, in a matter of, 2 days, though, all the 100 beds got actually filled up. And then all of us decided that, again, we need to tone down. And even the patients, suddenly the outpatients started going empty. People were wanting more tele consultations. So, in the Arthroplasty practice is almost zero at this point, because Kolkata is going through a big spurt. So, at the moment, it's zero. The question I would want to ask later on, time, is I heard that the doctor from Korea and China, Dr. Wen, are doing their medical people tested. But it not be totally done for our facilities here. So should we as doctors be doing at least the IAA, the antibody testing, or should we then get all staff tested? This will be my question after we finish about the one you said.
Hello. Yeah. So, Dr. Maria, you are in a different setup. Like you are an orthoplasty surgeon, and you are also a director of your department of orthopedics. So, does it matter, how the rules and regulations, protocols to be laid down, and what pressure you have in current time when we are resuming the work again?
Well, let me start backwards. Technically, this time there is no pressure, because I think it's everybody, doctors, managers, politicians, and buy watchers are all equally concerned and worried. Now, the point is, even as a director, or chairman of my department, my job is basically to just keep these people, the blood from boiling in the younger surgeons who are desperate to wield the knife. And I don't blame them for it. They're all holding very well, I must say. But the point is, the only difference from all that I heard is that we do not accept at the moment anybody with comorbidities. We are very particular about, especially starting from top downwards, chest, cardiac, and then diabetes. And diabetes, anything above 7.5 HbA1c, we tell them go. The easiest thing is to tell them to go and bring it down to 6.5. That will give you a year or two, or by that time COVID hopefully would have blown away into the sea. But the point is that the most we heard earlier, I'm sorry I'm coming back, there is no value of a consent. The only consent, I know this because I have taken legal opinions. This is close to my heart. The only consent which may hold some value is the one written in the own writing of the patient, literally requesting you to operate, otherwise he'll go somewhere else. He's hell-bent or she's hell-bent on getting operated. So, has to write that in the own handwriting and signed. Only then you are somewhat safe. Otherwise, I'm afraid it's better not to go into it at the moment.
Okay.
That's how we are working.
Yes. Thank you. Bharat bhai, your situation is absolutely different because you own such a big hospital. Now, if we see our registrations today are 440, and the data collected, which says there is loss of 19,000 joint replacement surgeries. And we expect this to come back at least 6 to 7 months into the normal count. So what's your opinion on how you are managing in a new normalcy once the lockdown is open?
Sure. So the one thing that I can confirm is that universal experience across our country, wherein after the lockdown, we had a window period of about a month before community transmission took firm root in our country. And therefore, for that 1 month, we could get on with some business. And I'm using the word business with all due respect. What I did want to bring home to my colleagues here, the one protocol that we have adopted is I got especially my OR people and also my ward staff nurses, all of them, I got them screened with IgG antibodies. We ended up getting about 30% of our staff members who revealed developed antibodies, whether they had any symptoms in the last 2 months or not. Okay. Now, what we have done is we make these IgG antibody positive personnel to come close to the surgeon. So in other words, if you have scrub nurses, 3 or 4 have G positive, we make them as the front line assisting guys in the operation theater, and the others remain in the circulation, so that there is some sort of a logic that maybe these girls or boys, will not have COVID positivity in them. Although I'm not too sure of this on a scientific basis. It might be that they are safe, not necessarily the others. They might still harbor the virus in them. But because it is impractical to test people every day, and that's why we take this sort of an educated guess, if nothing else. Now, coming to the business part, as you said, yes, you are right. That's almost, we at the moment, let's say the first quarter is over. April, May, June, the first financial quarter is over. And I would be quite honest in saying that our P&L, the profit and loss accounts, show that we barely managed to cover our fixed expenses and a bit of the variable expenses during these 3 months, because the overall rate of the volume of arthroplasty and elective work that we did in our hospital had fallen to about 25% of the normal volumes that we would otherwise have done in these 3 months, let's say, compared to the previous year. I don't see this changing in India, or at least in certain urban areas, for another at least 3 months, because if you look at the epidemiological projections that have come from Johns Hopkins and other large institutions who have taken the Indian demographic model and population densities as their basis of calculations, they expect that India will take at least up to December before it will peak out, and it will start slowing down. You know that our figures as published as official data are nowhere near what our experience is on the ground. So the fact is that we will all have to be prepared, whether corporate hospitals or any other private setup, we will all have to be prepared to tighten our belts and modulate our fixed financial costs in a manner which allows us 2 or 3 things, hopefully. One is, it allows us to survive as a business entity. Number 2, it allows us to retain at least the core staff members who form the nucleus of the collective institutional skill sets in different departments. It's not only about OR. Remember, as a CEO, I know that my HR or my maintenance team who looks after my chillers, air conditioning chillers, or my DG set, etc., diesel generation set, they are all as important as the scrub nurse in the operation theater, because they are the one who knows the pathology and the anatomy and the physiology of the building. So all these different segments of an organizational structure, we will have to ensure that we retain at least a critical number of them who know, therefore the institutional memory doesn't get wiped out as and when times turn a bit better. And as far as implementing all these preventive protocols is concerned, what I do is, there's no point repeating all this. All I'm saying is that to say that we use X level of PPE, etc., is easier said than done on a consistent level. I'll give you my own example. I find it almost impossible to withstand the claustrophobia that I feel when I am completely in a PPE and trying to then operate on a patient, especially, say, a hip replacement. I think I would die not of COVID, but of the suffocation and the heat exhaustion that I would have if I had to do it on a day after day, maybe 3 times a day type of a practice, in handling. So all I'm hoping for is we are reducing our numbers of operative work to the extent, not that I have to reduce, they are already reduced, but I'm spacing them out. So let me rephrase it. I'm spacing them out so that we can do it at an easy pace. The density of population, both the office or the hospital staff as well as patient members from the outside, that's all at a very base minimum, which allows me just about to surf on the surface without sinking. And I'm waiting to see whether we can gear up our volumes as things hopefully improve. And the only 2 things that I see here is, one is if there is a natural slowdown as we saw in China, in Wuhan itself, after the peak had passed by, or some vaccination strategy comes along which allows us to ease ourselves a bit more rapidly. Although that is a bit far away, because even if a vaccine does come, to try and vaccinate a sizable population in itself is going to be a incredible challenge. As you know, it took decades for the polio vaccine to be administered to the entire population for polio to have been eradicated. So decades, and this is an oral vaccine, which is so much easier to administer. So we are looking at an extremely tough time, and anyone who has a business hat or has the need to put on a business hat, they need better start working on protocols of fixed cost, and it's not the subject area of this webinar, so I won't go into any further details on how to look at the various revenue streams and the various expense streams to try and rationalize and balance out your the business side of this entire exercise of treating patients. I guess that covers the question.
Thank you, Bharat. Very, very exclusive talk. Now, our president who works at two setups, he works at a government setup or like a PMC setup, and he works in private setup. So how do you see, Dr. Mohanty, the restarting of joints in this time when you're working in two places, different places?
Regarding this consent and all these things, I always explain the patient that the risk is taken by both of us. It is not only the patient, it is I am also taking the risk of I may develop a coronavirus after the surgery as well. So that way, even if it is legally unsafe, but at least psychologically the patient is bit satisfied that my surgeon tells that he is also at risk and I am also at risk. So they give a consent for any trauma or any arthroplasty setup. Okay, regarding the public setup is entirely different. In public setup, we are always run in constraint, and we cannot get adequate number of testing done as we do in privates, like doing a RT-PCR, doing a CT scan, doing an antibody test. No, still now we are not doing test for each and every patient. What we do in public setup, that patient can stay for a longer time in the ward. So we admit the patient in a separate area, these patients, and we keep them for at least 5 days, 4-5 days, and look for any development of the symptoms is asymptomatic. If it's symptomatic, then he goes to the COVID ward, or after 5 days. Then if he doesn't have any symptom, then we go ahead with the surgery and we put on our PPs. We take that risk both for the patient and for ourselves as well. But having said that, on the private setup, it's a time, and in a private hospital, at least after doing a RT-PCR test in private hospitals in Mumbai where I work, they tell that within 48 hours you have to operate the patient. If your time of testing and your surgical time is beyond 48 hours, again we have to repeat a test of RT-PCR. So RT-PCR, CT scan, we don't do antibody testing routinely, but only these two tests and operate the patient within 48 hours. And then, post-operatively, if the patient doesn't have any symptoms of COVID, then he goes home. But if it develops any symptoms like fever or, any cough or anything, then we have to test again after the surgery. So that is the way to go. From consent of view, both in private and public hospital, I always tell the patient beforehand that both of us are taking risk of doing the surgery. There is a possibility of developing COVID after the surgery. Yeah, you have to unmute, Sanjeev.
There's a question from yeah, I've done it. So there's a question, like for the teaching of the students, you have all these cadaveric sessions for the joint replacement orthoplasty. Now, post-COVID, what difference it will make in a cadaveric teaching of joint replacement? So we can start from Wuhan first. Dr. Zhu.
I'm sorry, I didn't hear the question clearly.
Okay. The question is, for the teaching for the students, you have a cadaveric dissection or section doing a joint replacement orthoplasty, right? For the students. So the post-COVID, what difference it will make? Like you are allowed to do a cadaveric dissection, or you still have to wait, and how long?
Cadaver?
Training on dead bodies. We do training of the residents for exposure, for surgical experience on a dead body. What we do.
Okay.
You understand?
Can we take Professor Baik?
I am really willing to my students one by one, but not all, one by one. Encounter the cadaver dissection because I just imagine that this cadaver is COVID positive. So maybe he needs some full equipment, personal protective equipment. So that's a good training before the real patients is encountered. So I am willing to participate in my one students into the cadaver. Not all, one by one. Not crowded.
Dr. Michael.
Cadaveric dissection is not part of routine teaching for undergraduates or even for orthopaedic registrars. The companies occasionally run cadaver workshops for surgeons, but training on cadavers is not part of Australian medical school or registrar training, I'm sorry to say. So it's a question that will have to stay in the realms of hypothesis as far as Australia is concerned. That's not a feature of our medical school. We just don't have enough dead people.
Okay, so quick answer by each Indian faculty, starting from Dr. Maria.
Yeah. Sanjeev, I think these are hypotheses and level 5 evidence that you are seeking, that what will happen and how it will happen. I don't think we have answers. We'll wait for data to come in, and we'll have studies even on cadavers, maybe in proper labs, to find out if it is safe to operate them and how many days. Say there is a patient who had corona, he died, his body was either donated or unclaimed, and then a test is done 7 days later. And if like that on a few instances, if it keeps coming negative after that much time, you can do it. I personally don't see a problem after a few days.
Krishna.
Doing cadaveric dissection after a few days of waiting. I don't see a problem.
Okay. Krishna, quick.
The corona bodies are disposed of in a different way, so they will not be handed over. So the ones which are donated will probably not be having any corona. The more problematic will be to organize a group meeting and the issues of social distancing when so many people come and work there. So I don't foresee any cadaver dissection for the next year or year and a half at least. So till this epidemic or pandemic goes off, there won't be any cadaveric dissection. Now, what about cadaveric? I don't think there will be any meetings also where people will conglomerate in large numbers, because that's what has been shown to drive the spread of the virus itself. So at least for a year, there won't be any meetings. That's what. So whether it's cadaveric or non-cadaveric doesn't make a difference.
So do other faculty agree to that?
Sanjeev,
yes.
Just a small comment. You know what? Even if from what we have now understood as for the world at large, and certain visionaries like Bill Gates, when you go back to his lectures about how the pandemic could have been already been foreseen. Well, let us understand SARS, MERS, SARS-CoV-2. We are now onwards going to live in an environment where one or the other virus is going to crop up, and we as a population will be forced to adopt certain life-changing practices, which includes meetings like this as becoming more and more standard, because you can have a vaccine for SARS-CoV-2, and the next time from our Indian vegetable market, this time there could be something else which spreads around. Or so we as a people will seriously have to apply our mind what to do. The fact of the matter is that all these are results of two things. One is the incredible velocity with which human beings now travel across the planet because of the wealth and the transport capabilities possible by human race. And second, the sheer density of human numbers that now inhabit this planet. And these two things are not going to be changed. And the only thing we can change is maybe apply our mind to what just now Krishna Kiran said. Trying to work out whether a cadaveric workshop is possible is, in my opinion, an electron microscopic dot on the overall problems that we are going to anticipate. With that, I take your leave, gentlemen. It's been an absolute pleasure interacting with all of you. Thank you.
Professor Mohanty, can we conclude?
Yeah. Thank you. Thank you, esteemed faculty. Thanks, Dr. Yu, Professor Beck, and Dr. Gillespie, I think it's a late evening in Canberra now. Thank you all for
That's okay.
for this webinar, and I thank all our Indian faculty, Dr. Maria, Dr. Bharat Bhai, Dr. Krishna Kirar, and Dr. Rakesh Rajput for joining from different parts of India and sharing their experiences. It was an excellent webinar. And last but not the least, our own Vice President, Dr. Sanjeev Jain, has taken all the pains to organize this right from the beginning. And it has been really enlightening for all of us and for all the faculty as well. On behalf of the Indian Arthroplasty Association, I express my gratitude to all of you for being there and in this event. I declare that now the next webinar, that webinar number 8, will be next month on 15th of September. That will be totally arthroplasty post-trauma, and the moderator is Professor Ramesh Sen, and we'll be organizing that. We'll soon be releasing the program for that. At last, we are grateful to entire team of Johnson & Johnson, especially their professional product manager, Mr. Balaji Ramurthy, and the entire team for for supporting this event. And also Anand, the team who is on the backbone of organizing this audiovisual source. Thank you all. We close down the meeting now. Thank you very much.
We also thank all the participants. All the participants, and kindly give us the
Thank you very much.
Questions. Thank you, Dr. Gillespie. Thank you, Dr. Zhu, and Dr. Baker.
Thank you. It's a pleasure and a privilege. Thank you very much.
Bye. Bye.
Bye, everybody. Thank you.
Bye. Thanks.